begin, I'd like to just quickly introduce everybody to some of the webinar tools that we'll be using today. The first is the ability to raise your hand and ask a question. You should be able to find on your dashboard, which should be on the right side of your screen, a hand-raising button. What I'd like to do is I'd like everybody just to punch that button right now so that I can make sure that people have the hang of it. So go ahead and hit that. Don't worry, I'll be able to put all the hands down afterwards. Excellent. Okay, looks like pretty much everybody's got it. Great. So that is one way that you can indicate that you have a question. And if you raise your hand, what I will do is I will open your microphone and allow you to ask your question to Dr. Goldfried directly, and that way you can engage in a dialogue. If you don't have a mic connection or you'd prefer not to ask the question in person, you may type the question. If you look at the Questions tab on your control panel, you can type a question. You should also use that Questions panel for any technical questions that you have. So if you're encountering any problems, just type your question in there, and either Kim DeYoung or I will answer it. Okay, so what I'd like to do now is I'd like to turn things over to Dr. Goldfried.
I just have to record it, so that's...
Welcome to GoToWebinar, Web Events Made Easy.
Really requires little in the way of introduction. He's so well known to our audience. But I will just briefly say that he's the co-founder of the Society for the Exploration of Psychotherapy Integration. He is one of the past presidents of the Society for Psychotherapy Research. And he has also founded a group called Affirm, which is a network of psychologists and researchers who very openly support and affirm their lesbian, gay, bisexual, and transgender family members, colleagues, and clients. So with that, I'd like to turn things over to Dr. Goldfried, and we will be pausing for questions as they come up and as there are sort of natural breaks built into the presentation. Marv, take it away.
Thank you very much, Sam. I hope the audio is okay with everyone. This is the first time I've done a webinar, and it's a little bit weird, but I tend to think in visual pictures. So I can picture you all throughout the world eagerly awaiting, or maybe not so eagerly awaiting, what I have to say. And I hope that we can weave in a certain amount of interaction during the presentation. So the title of my presentation is Psychotherapy Integration Past, Present, and Future. And I'm going to focus on two things. There we go. The integration of different therapy orientations, which is something that I've been involved in for over 30 years now. And the focus there is probably the primary theme on which CEPI was founded, namely to open up a dialogue so that therapists from different orientations can talk to each other in a way that was a bit unusual at the time. Namely, instead of trying to convince somebody from a different approach that they're wrong and that you're right, the dialogues that we've been interested in and have fostered is to learn from each other and to see whether or not we can find some common ground and hopefully work toward improving our approaches by benefiting from what other approaches had to offer. So we've done that for the past 3 decades or so. And Society for the Exploration of Psychotherapy Integration, CEPI, some of you on the webinar are members of that, also has been expanding its mission for the integration of research and practice. And I'll have more to say about that during the second half of the webinar. But let me start first with the integration of different orientations. And in these presentations, I'm going to also weave in personal experiences that I've had over the years, which parallel kind of the change in thinking within psychotherapy. And you'll see, to a very great extent, I grew up professionally with behavior therapy, cognitive behavior therapy, psychotherapy integration, evidence-based treatment, and also I can weave in my personal experiences with the kinds of things that I see are needed for the field more generally. So one of the things that I'm particularly interested in when it comes to different orientations is my concern that we put, as professional therapists, we put too much of an emphasis on our particular orientation to the exclusion of contributions that might be coming from other approaches. And this limits what we can do and limits our effectiveness. And an example of a limitation, here's an illustration of a therapist, male therapist, supposedly what I looked like a few years ago. My son drew this cartoon. And here I am, or here the typical therapist is greeting a new patient. And she's wondering, I hope he treats the problem I have. And at the same time, he's thinking, I hope she has the problem I treat. And I think this kind of represents where we are in the field of psychotherapy. We're not quite stuck there because I think more people are open to the notion of integration, but I think we need to move ahead. One of the things that that you need to know is that my original training, which was back in the 50s, was primarily psychoanalytic, because that was basically what existed at the time. And it was both psychoanalytic and it was both non-empirical. So it created a dilemma for me because not only was I learning about different psychodynamic approaches to intervention, but also part of my graduate training was quite rigorous, learning about research methodology, learning about learning theory and research. And there was this incredible discrepancy that existed between the psychoanalytic notion of how people change and the learning notion of how people change. And one of the things that I found very heartening was a book by Dollard and Miller, which was published in 1950 and called Personality and Psychotherapy, where they translated psychodynamic concepts into learning terms. And this was very, very helpful to me. And I remember one day in the graduate class I was taking on learning, this was in the late 50s when Wolpe came out with his book on behavior therapy based on learning. I said to the instructor, this is very, very exciting. You know, at last the field of psychotherapy is going to be based on what we know about research and learning. And the instructor looked at me with some disdain and said, oh, it's a lot of crap. It'll go nowhere. So much for predicting the future. What happened is that as I was on the job market, I noticed that there was an opening at a university, new university on Long Island, New York, outside of Manhattan, called the State University of New York at Stony Brook. And one of the things that they were going to be doing was building a clinical psychology training program that would be based on research and theory in learning. And this was like a dream come true. I applied for the job, I got the job, and we had a graduate program we started. And most of what we were doing was, this was in the 1960s, was training our students in behavior therapy, even before cognition was entered. And in the U.S., in order to have an approved clinical psychology training program by the American Psychological Association, there needed to be certain criteria you would meet. And they would periodically visit the campuses to see whether or not they were living up to certain standards. So the American Psychological Association came to Stony Brook and they saw the courses that we were teaching and they said this was not good. It was much too narrow. We needed to expand and teach our students more than just behavior therapy. I was teaching a basic course on that, and the clinical faculty said well, you've got to teach them more about psychoanalytic stuff. And I said, I've been there and I've done that, and I really don't want to have to go back. And they said, we have no choice. If we're going to be accredited, we need to do this. So I went back to my old notes, and I went back to my textbooks and started rereading stuff, and noticed, quite to my amazement, that a lot of the things that were being said were very, very similar to behavior therapy, except it was being said in very, very heavy theoretical jargon. And then it occurred to me that here we have different approaches to therapy that are trying to advance the field, but there's no communication at all between them. As behavior therapy started introducing cognition, this provided a very important pathway with which we could talk to our colleagues of other orientations. And there were interesting links. And Paul Wachtel, who's psychodynamic, and myself, at the time I was cognitive behavioral, decided we would meet and talk about the possibility of talking to each other as different orientations. And we had a series of meetings. I was living in Manhattan, and he was living in Manhattan, so we would have lunch together. And after several weeks of doing this and having some exciting conversations, many of them on the streets of New York, we decided that we needed to take a leap to the next step. And that was, we started having dinner together. And we had lengthy dinners, and then we started bringing other people into the fold, people who recognize that no one orientation can handle all the complexity of human behavior and how people can change. Other scientists have recognized this. This is nothing new. There are two very well-known scientists who have spoken about this issue, indicating that their theories cannot explain the complexities of the physical world. And Einstein said, alas, our theory is too poor for experience. And he was talking to his colleague, Niels Bohr, who said, no, experience is too rich for our theory. So I would maintain that there is no theory of therapy, no theory of human behavior and functioning currently existing that can handle the complexity of human functioning and the change process. So what I want to move on to, and I'll entertain questions in a few minutes, but let me just make a point of how we can go about seeing the similarities across different orientations. And I'll offer a couple of ways. One is how we can view the change process in a very general way, general enough so that we can fit our own particular orientation into this. So we can talk about 4 general stages of change that can apply to different approaches. In the first stage, our patients come in, they're distressed, and very often they don't know why they're distressed. Their life is not working in the way they would like to see it work. But they are unaware of the factors, either from the past or their current life, that are creating difficulties. They are ineffective in dealing with their world, or we could say they are incompetent in dealing with their world, but they don't know why. So that is the first phase that we can call unconscious incompetence. One of the earliest things that therapists do, regardless of orientation, is to help the patient become better aware of what is going on in their life and why it's going on. So we could go back to past history and factors in the past that contribute to where they are now, or we can also look, in addition to that, to current factors that are limiting our patients' incompetence. So they become better aware of why they're having difficulty, and we could say that they are in the stage of conscious incompetence. and an insight-oriented approach and the cognitive aspect of behavior therapy certainly contribute to bringing the person from phase 1 to phase 2. And then at some point, the patient will say, well, now that I know why I'm having so many problems, what can I do differently? Well, they are now moving into the stage of learning to be competent, but in a deliberate, conscious way. And behavior therapy, I think, has made the most important contributions in giving us insights as to how this can be brought about, with its basis of learning and relearning, in its historical foundation, but also other ways of getting people to change their functioning and reduce their adverse emotion. And this occurs to a great extent in behavior therapy. Psychodynamic approaches spend more time in phase 2, but eventually get to phase 3. And as people start doing things differently, with deliberate effort, and become more competent, it becomes easier and easier, hopefully, and this is if therapy is successful. So there's a relearning, and there are clearly changes in neural circuits over a period of time so that they can become more competent and function more effectively without the deliberate effort. And here they reach the stage of unconscious competence. And it's a very, very useful way, not only for us as therapists to think about the change process, but I have found in my own clinical work, and I do therapy 1 day a week, and have been doing that for years, I find that the clients that I work with take this notion and they can know where they are at in the change process. And some of my clients use this jargon to me and say, I think I have moved from conscious competence to unconscious competence because I did something differently that worked, and I did it without thinking. So this is one way in which we can dialogue and think of changes, think of commonalities across different approaches, even though the content of what is done in these phases may differ from orientation to orientation. Sam, are there anybody with questions?
No, so far we're in good shape. Let's just take a quick pause, and if anyone does have a question at this point, why don't you either raise your hand or punch it into the question box, and I'll be able to get you connected with Marv. So it looks like so far nobody has any questions, so I would suggest that you just keep going.
Well, it must be because I'm crystal clear and I'm stating the truth.
That was my assumption, yeah.
There's no debate.
No.
So this is one way to do it. Another way is to think at a different level of abstraction than we usually think. And this is certainly a good start because we're talking...
Oh, Marv, I'm going to jump in because we did get a question.
Okay.
The question comes from, oh, good, we've got a couple actually. Okay. Piero Pocelli wants to know, why do you call phase 4 unconscious competence?
Okay. The phase of conscious competence involves having the client do things differently than they had been doing previously in their life. And they're learning a new way to function. And the more experience one has, the more automatic the functioning becomes. And consequently, it's unconscious because it's a different meaning of unconscious than here. It's unconscious because there's a greater sense of being automatic. It can be done without thinking.
Piero, does that answer your question, or do you want to ask a follow-up? And your microphone is open, so you can actually speak if you want.
Okay, thanks.
Okay. Okay, let's look at, so the next question comes from Patricio, sorry, I'm going to murder this name, but I'm going to try it anyway, Patricio Olvos Aragon, who asks, it seems to me that these stages are similar to the assimilation model of William Stiles. Any thoughts about that, Marv?
I would hope it would be similar to Bill Stiles' model. I would hope it would be similar to Prochaska and colleagues' stages of change, because what we're doing is we're talking about the same phenomenon. Bill Stiles is a little bit more theory specific. It tends to be linked much more to psychodynamic, whereas I think this tends to be a much more general type of thing. So I'm trying to move to a level of abstraction that gets beyond theory, and basically what I want is Bill Stiles to say, yes, I agree with this, and I want Prochaska to say, yes, I agree with this, because the extent to which they do agree, even though it may be similar to what they have presented from their point of view, it says that we have a starting point for us to come to some consensus.
So we've gotten a bunch more questions following these. So we've got, are the stages that the therapist goes through, are there stages that the therapist goes through that parallel the 4 stages for the client's awareness? And that comes from Mary Coombs.
If what you mean by the stages that they go through, it's like what they need to do, absolutely. At this stage, they want to increase the client's awareness of factors that are contributing to their lack of competence. Once they reach this, in a sense, they would be on the same page and they would be in agreement, so that you've moved from here to here. So the explanation, the insight phase is here. Moving from incompetence to competence, it's essentially the risk-taking or the behavior change. So the therapist focuses on getting them to do things differently. And the Prochaska model certainly deals with this kind of thing. And then moving from here to here, the therapist should pay attention to when the person is reporting having done something differently, and you ask them, how did that come about? And they say, well, I didn't have to do it deliberately. It just kind of happened automatically. And that kind of tells you that the level of competence has moved from awareness to becoming more automatic. So it does provide the guideline. That's an excellent question. It provides the guideline not only for the patient to know where she or he is at, but also for the therapist to know what is needed by the patient.
Mary, if you have a follow-up, we've opened your mic, so you're more than welcome to ask.
Okay, no, that's good for a start. You're doing fine.
Okay.
Okay. So our next question comes from Maria Guerrillo. Maria, we've opened up your mic if you want to ask your question. But you may not want to ask your question. Maria, are you there? Okay.
Hi.
So, oh, there she is. Okay. Would you like to ask your question?
Yes, hello. I would like to know if you discuss the 4 stages with your patients openly so that they can identify them in the process, and I'm thinking that maybe it is helpful for them to guide the process. That's my question.
Yes, I absolutely do that. I totally do that. And we make reference to it during the course of treatment. It's important for them to know, at least from my point of view, it's important for them to know what the stages are, because they are the active participants in bringing about change. So to move from unconscious to conscious incompetence, they need to become aware during the course of their life, when during therapy, when things are not working for them, and then to know, oh, they're not working because I have this sensitivity, this vulnerability to think that I am not going to be getting what I wanted for my significant other because I never got that growing up. So that's maybe why I'm angry. I'm anticipating I'm not going to get that. So I am aware of this. Let me get my cursor here. I'm aware of this, and this naturally leads to maybe I should think differently. Maybe I should give my significant other the benefit of the doubt and not assume that she or he is going to reject me. So maybe I should approach them in a different way. And so they are moving from one to the other, and they know that. And this is a fairly easy thing for them to remember, although from time to time I find I need to remind them as to where they are and to label it. But this does, I find, help facilitate the change process.
Okay, so we have one more. It's a comment from Namhi Stokvis. I wonder, Namhi, we'll open up your mic if you'd like to speak. Namhi, are you there? Would you like to deliver your comment?
So can you hear me?
Yes.
Yeah. It was just a comment for the first question, about unconsciousness and consciousness, because sometimes people get confused because they interpret those terms as a psychodynamic terms. But I think in here,
I'm having trouble hearing you now.
It is more used as just like the Dr. Goldfried said, it's more automatic, and so consciousness is aware. You're awareing, your thoughts and problem, and you're awareing your change. Unconsciousness is you are doing automatically, or you haven't really aware of it yet. So I interpret it that way, and then that kind of clarify the term. So I just wanted to make a comment.
Okay, thank you. But that was a comment, not a question, correct?
Yeah. So Marv, we're through questions, and you should carry on.
I will carry on. Okay, so following along with the theme of changing our level of abstraction in how we think as a way of looking for commonalities, we can see that there are different levels of abstraction in conceptualizing psychotherapy. At the most abstract level, we have a theoretical orientation, whether it's psychodynamic, experiential. I've got to minimize this screen. Whoops. A little technical difficulty. Okay. So we, in very broad terms, we have a psychodynamic approach, an experiential, and a behavioral approach. Clearly, it's very, very broad, but let's just work with this for a moment. At the lowest level of abstraction is the clinical procedure, and that is what we do. We interpret, we reflect feeling, we self-monitor. And what we do often is related to our orientation. Whoops. Let's go back. So for psychodynamic, we interpret. If we're experiential, we reflect. And if we're behavioral, we ask for self-monitoring, where the person will observe their behavior. But somewhere between these two approaches, we have the general principle. And some people call this common factors. I don't like the term common factors. I think of it more as a principle of change rather than simply a common factor. I mean, a common factor is both across orientations, is that a therapist sits while doing therapy and is usually sitting opposite the client who is also sitting. That's a common factor, but it does not contribute to change. The general principle contributes to change. And what I would say is that if we're going to look for a common base by which we can talk to other therapists, a common base that we can think about when we do therapy, a common base that we can think about as researchers when we conduct therapy. It's at this middle level of abstraction. So what is the function of interpretation? To increase awareness. What is the function of reflection? To increase awareness. What is the function of self-monitoring? To increase awareness. So I consider principles of change to be very, very important, because if we can find general principles of change that have managed to survive whatever schematic distortions our theories force us to make, if we can find common ground, then it must be a very robust phenomenon, that there's truth there, that this is general principle is an important way to think about therapy. So let me give an example of general principle, the engagement of or encouragement of corrective experiences. And this comes from the work in the 1940s of Alexander and French. And Alexander and French were psychiatrists that were, they were rebels. They thought differently. They were psychodynamic in nature, but they thought that the change process had to do with learning. As a matter of fact, Thomas French, at the 1932 meeting of the American Psychiatric Association, pointed to some similarities between Freud and Pavlov, that there was learning in psychoanalysis. So they proposed the notion that sometimes change is possible in therapy without the person having to go back and understand its historical roots, and without having to go back and resolve unresolved conflicts. And it's done by providing new corrective experiences. So where does this show up? Well, those people who are schooled in CBT will know that it's this. And that is extinct. This is Albert Bandura in the 1960s, heavily laden with learning jargon. Extinction of avoidance behavior is achieved by, repeated exposures to subjectively threatening stimuli under conditions designed to ensure that neither avoidance, that is, they can't avoid the situation, or anticipated adverse consequences occur. What does this mean? Well, it turns out there's a psychoanalytic writer who many years before said exactly the same thing, but said it without jargon. Whoops. And that was Otto Fenichel. When a person is afraid but experiences a situation in which what was feared occurs without any harm resulting, so no negative consequences, he will not immediately trust the outcome of his new experience. However, the second time he will have less fear, the third time still less. Repeated exposure. So we go back to Bandura and we see it's the same thing. Repeated exposure, no adverse consequences. This was published in a book, thin book in the 1940s on psychoanalytic technique of how to do psychoanalysis. And Freud said pretty much the same thing at one point. And a famous first lady, that is the wife of a very famous American president, Roosevelt, Eleanor Roosevelt was a very, very shy woman. And because her husband was president, she had to speak in front of the public and had to overcome her shyness. And what she did was repeated practice with nothing bad happening. And as a result of that, she came to the conclusion, you must do the things you think you cannot do. So here's my point again, that the extent to which we can come up with a common principle of change that fits different theoretical orientations with all its theoretical complexity and the possibility of excluding any other way of thinking, the more we can come to a common ground about change, the greater the likelihood that it's a robust principle of change. Now we can get into the next phase of what are the common change principles, but let's see if there are any questions before we do. Anything, Sam?
No, let's see. We've got one coming in from Patricio again. Give me a moment, Patricio, and I will open your mic. All right, your mic is open. Go ahead. Patricio, you can ask your questions.
I don't have the. Oh yes, as a psychiatrist, I'm interested in supportive therapy, and I think that these general principles are useful strategies and techniques in the process we live with all kinds of patients in a theoretical way.
Good. Thank you.
Yeah. And so that's all we have for now, Marv.
Okay. So what are the common change principles? Notice I'm not calling them common factors because I try to be a little bit more specific. It's how change comes about. Okay. First, the expectation that therapy will help. Jerome Frank has written about this and how about positive expectations can build a sense of hope. People who are dealing with unmotivated patients have written about this and have done experimentations on how to increase a person's motivation. And as practicing clinicians, we know that if a patient comes in because they were told to or forced to come in, and they think that basically this therapy stuff is junk, and they do not have the expectation that therapy will help, whatever great insights or techniques or principles we may have that can bring about change, it's not going to work. And we know that. There's got to be motivation. There's got to be a certain amount of positive expectation. And these notions have been around for a long time, and people are doing research on this. Mike Constantino has a research program that deals with positive expectations. And Miller and Rolnick and others have a research program that deal with motivational interview. It's the old joke, you know, how many therapists does it take to change a light bulb? And the answer is only one, but the light bulb has to want to change. So we need to have expectation, we need to have motivation. And if the person comes and does not want to change, then this becomes something we need to do. The presence of an optimal therapeutic alliance. More and more we know about how important this is. Interestingly enough, in the 1960s and even 1970s, behavior therapy and cognitive behavior therapy did not really recognize this as being very important. The label that has been used historically by behavior therapists are the non-specific factors of therapy. And it's called the non-specific factors for two reasons. One, it's not specific to the change process because the change process presumably is learning. And also we can't specify it because it has something to do with the relationship, and as behavior therapists, that's less important than the technique. So that's the reasoning. That reasoning is falling by the wayside, fortunately, but has not disappeared among some behavior therapists and cognitive behavior therapists. Because it has been demonstrated that the alliance is crucial. There's been research on that. If we don't have a good alliance, a client may not return. When I teach my graduate students how to do therapy, I say to them, the goal of session 1 is session 2. That if you cannot create some semblance of at least a basic alliance, the client will not come back, no matter how great your techniques are. So what is the therapeutic alliance? Well, interestingly enough, it came out of the work by Ed Borden, which was the outgrowth of a psychodynamic approach. And that is, the alliance is composed of the interpersonal bond, that is, how good a contact and communication and chemistry there exists between the therapist and the patient, a sense of trust and all of that. So that's the bond. The second is an agreement on goals, and the third is an agreement on methods. And there's been a lot of research done on that. And still, there are behavior therapists and CBT people that play this down. They say it's unimportant, it doesn't exist. Well, I think it exists in the background, but they're not aware of it. And when I teach about the Therapy Alliance to CBT people, I tell them a story. And it's a story about a man who works in an electronics factory that produces very expensive and sophisticated electronic parts. So much so that at the end of the day, everybody that works in the factory has to pass through a gate and be searched to make sure that they are not stealing anything. So one day, one worker comes by and he has a wheelbarrow. And in the wheelbarrow is sawdust. And he comes to the gate, and the guard at the gate said, "What do you have in the wheelbarrow?" And the guy says, "Sawdust." And, of course, the guard looks at him very suspiciously and sorts through and looks into the sawdust, can't find anything, and he says, "Okay, go ahead." The next day, the same thing happens. He comes with a wheelbarrow full of sawdust. And the guard said, "Okay, I'm going to look more carefully this time. Can't find anything except sawdust." And he says, "Take it. We don't care." This happens day after day. And finally, the guard is very, very suspicious. And he takes this man aside and he says, "Listen, I know you're stealing something. And I promise not to say anything. Tell me, what are you stealing?" And the guy looks at him and he says, "Wheelbarrows." So to CBT therapists, the relationship is the wheelbarrow. It's invisible to them because they're paying attention to what's in the wheelbarrow. But the technique is being delivered in the context of a therapy alliance. And there are data to show that some therapists are better than others. Any questions, Sam?
We had one, but you answered it in your last discussion of sort of some of the nuance about sort of CBT therapists and their impression of the alliance.
Okay.
I think that, sort of a follow-up to that would be sort of how prevalent is the perception that the alliance is, important but not necessarily vital for change in psychotherapy within CBT?
Not as prevalent as one would hope, and I'll touch on that when I get to the second portion of the webinar.
All right, so that's it for now.
Okay. The next principle is helping patients become better aware of themselves and their world. You can see how this parallels moving from unconscious incompetence to conscious incompetence. Learning about the factors that are motivating and determining their behavior. So let me say a little bit more about this so that we can all relate to this principle from our own orientation. So from a CBT point of view, it's pretty simple, straightforward. And that is having clients and patients become aware of how their emotions are affected by their thinking, by their automatic thoughts, by their schemas that have been learned early on. So having them see the link between thoughts and feelings. But there are other things that they need to become aware of. Some are not even aware of having emotions. They may be angry and not be aware of that. I have seen this in many panic patients who have been taught not to be angry, but their body experiences the anger, and that is the fight or flight reaction to a stressor, often an interpersonal stressor, and their heart beats faster, and they sweat, and they have difficulty in breathing, but they don't know what it's due to. So the link between cognition, emotion, and physiological reactions is something that a person would have to become better aware of. Other people need to become better aware of the impact that they're making on others, that they may not realize that the behavior of other people is a function of what they've done, but they don't know the impact that they're making. So this awareness component becomes very, very complex, and much of it depends on the nature of the problem. And certainly some orientations put more of an emphasis on this than others.
Marv, I'm going to jump in. I have a question from Tom Holman. Tom, I'm going to open up your mic and you can ask the question yourself. Go ahead.
Thank you. I have a question about using these change principles with young children, frequent population that I work with, who often don't want to comment, don't acknowledge the problem, and don't agree on goals and message. And sometimes one tries to change the child by working with the parents on behavior programs or environmental change. But in working directly with the child, it's a real, all of these principles seem to be things that you have to work towards rather than things that you can take for granted at the beginning.
No, you can't. That's right. And that's exactly the point. You can take this for granted. An adolescent who is forced to come into therapy because they're not doing their schoolwork, you can take a lot of these things for granted. And sometimes you can't have these in place, in which case there are clinical failures.
Great. So that's it for now. You can carry on.
Encouraging corrective experiences. And we've already used this as an example. And basically what we have here is it's behavior change. It's taking risks. A person has learned a certain pattern of behavior in growing up because it has worked and because they learned that within the constraints not only of the environment in which they grew up, but also any kind of constitutional genetic factors as well. So while it may have worked in the past, it doesn't work in their current life. And what they need to do is do things differently. They need to take the risk and behave differently. Why would they do that? Well, because they have an expectation that therapy will help, hopefully. They will have the motivation that comes with that. There will be an optimal therapeutic alliance where the therapist is trusted and the therapist is saying things are different now. Here's the way things are now. Become more aware of what is interfering with your life. Go from unconscious incompetence to conscious competence. And for all of these reasons, they're willing to take the risk and say something to a significant other they might not have otherwise said. And it works. Hopefully it works. And that's the nature of the corrective experience. It pays off. They come back to the session, and the goal of the therapist is to facilitate ongoing reality testing. This is the reality testing. What I've been avoiding doing, I can now do, and it works better for me. And it works better for me because I'm addressing those factors that have been interfering and now making deliberate efforts. So this is the corrective experience, and with practice, they do it again and again in different situations. This is much like the working through phase in a psychodynamic approach. What I would say about this is that we have literally a handful of principles of change, 5 principles of change. It's a lot easier to think during therapy about what principle is operating than to think about the hundreds and hundreds of different techniques that one might use. The relationship between techniques and principles is that the technique is a way of implementing the principle. So if we think in terms of principles, then we can think in terms of, okay, this person needs to have a corrective experience. What technique can I use, if there is a technique, to help facilitate and encourage this corrective experience? So the relationship between technique and principle, we don't do therapy according to principles. We do it according to clinical observables. But we can go from the principle, which is at the middle level, down to the technique. So not only is it useful for the practice of therapy, but this is where we should be doing our research, rather than doing research on a given theoretical orientation. I think it's important to do research on a principle of change. And my sense is that more and more people in the field are starting to think about this as a better way to do research, to think about the change process. Any questions?
No questions right now, Marv.
Okay. So, the integration of research and practice. I mentioned at the beginning of the webinar that CEPI had to do with the integration primarily, or the interface between different approaches to therapy. And I gave as an example the 1932 conference presentation by Thomas French, where he compared 2 different orientations, that is learning and Freud. But he also was comparing research and practice. And when CEPI started 3 decades ago, we had this as one of our goals and one of our missions. But we really spent most of our time, I would say 99% of the time, dealing with the integration across theoretical orientations. And now, as the field is becoming more pressured to show research evidence, we've changed our mission. We've expanded our mission to focus on this. Now, this has always been an important issue for me ever since graduate school. So let me go back to my graduate training. And I like to think of it, or I don't like to think of it, but I do think of it as kind of a training in becoming schizophrenic. Schizophrenic not in the professional, but more in the lay sense. And what I mean by that is that the clinical courses that I took in therapy, in assessment, which was largely projective techniques at the time, would be written in textbooks without any evidence base. It's so because the author says it's so. So there's a statement, but there's no citation in parentheses. On the other hand, I also studied learning and methodology. And in those courses, I was taught about the admissibility of evidence. And evidence has to come from controlled research. And that when you make a statement, you have to have a citation in parenthesis, otherwise lightning will strike you dead. And I would look at one textbook and I'd see citations. I'd look at another textbook and see no citations. And that was my schizophrenic education. One event, too, that seemed to underscore this was during my graduate training, we were fortunate enough to have a very well-known and respected psychologist visit our campus for a couple of days. His name was Paul Meehl. Some of you may know his stuff is still cited, and he had a private practice, but he was also a researcher and a philosopher of science, and wrote some of the brilliant work. And after his talk, we were asked if anyone wanted to go to dinner with him. And of course, I jumped at the occasion, and I went with some other graduate students. And it was very, very exciting to be in his presence because he was had read everything that he wrote, and he was talking about the importance of research and such. And at dinner, somebody said, Dr. Meehl, to what extent does research inform what you do clinically? And without hesitation, he said, not at all. As I'm saying this now, I have a visceral emotional reaction, not as strong as I did at the time, but it still exists. It's still stored within my brain. And I vowed at the time that something needed to be done about this. So a few years ago, somebody asked me whether I would run for presidency of the American Psychological Association, APA, Division of Clinical Psychology. And they said, what you can do if you're president is you can have a presidential initiative on anything that you wanted. And I thought, okay, what I really want is to close the gap between research and practice. And they said, fine, if you are elected president, you can work on that. And of course, they may have been snickering behind my back because people have been trying to do this for years unsuccessfully. So I won. And I started an initiative which we called Building a Two-Way Bridge Between Research and Practice. A few years later, somebody asked me if I would run for president of the APA Division of Psychotherapy, which was more practice-oriented. And they said, if you do, you can have a presidential initiative on anything you wanted. And I said, well, can I make it a collaborative initiative between the clinical psychology, which is more research-oriented, and the psychotherapy divisions, which is more practice-oriented? And they said, of course. So we developed an initiative, a collaborative initiative between these two divisions of the APA. And we formed a committee. And some of these names may be familiar to you. Of course, Louis certainly is, and here I am. And these were all people who were either practicing clinicians or researchers, but all had the feeling that we needed to close the gap. We need to close the gap. This has been a problem that has existed for years, and certainly since I was a graduate student. But what is happening in the U.S., and I'd be interested to hear whether you are experiencing similar pressures in your own countries, and that is there's much more of a pressure for research accountability. And these pressures are coming from governmental agencies, from insurance companies, from the threat of biological psychiatry, where psychotherapy will be put out of business by pills. And a lot of people who are doing research are saying that the clinician, the practitioner, is not paying attention to the research literature. We as researchers are trying to disseminate our findings, but the clinician is not paying attention. For their part, the clinicians are saying, you are making decisions about what therapies are valid or supported or empirically demonstrated without even asking me. I would like to disseminate my observations, my clinical observations to you, not my clinical speculations, my clinical observations. So when we developed this collaborative initiative, it was to be a two-way bridge between research and practice, where not only would the research disseminate findings to the clinician, but the clinician would also disseminate observations hypotheses for research to the researcher, because they've always, many of them have said, you're not studying the kinds of things that are important to me. I'm giving this webinar from New York City. I don't know if people can hear the sounds of Manhattan in the background. There's some construction going on. Is that creating a problem, Sam?
No, I mean, I can't hear it,
Okay.
and nobody's written in to say that they can't hear you well enough, so I think you're doing well.
Okay, I can hear it.
Can I jump in with a couple of questions?
Yes.
Okay. Danilo Mogia asked that we read a question, which is just relating back to the change principles. And the question is, it's a very interesting approach to change principles and to research in change, but it sounds, in some way, it sounds too behavioral. So I was wondering about the therapies where the conversation and dialogue is fundamental for change, like narrative therapy, open dialogue, or collaborative therapy. And I suspect that the sort of conclusion of the question is, you know, do you see a place for those change principles in those sort of therapies as well?
Yes. Well, certainly, if we go back, I don't see this as particularly behavioral. If somebody is not motivated for therapy, or they think that therapy is not going to help. The Therapy Alliance, quite the contrary, that is not behavioral, that is psychodynamic. Having patients become better aware of themselves, that is the essence of insight. At some point in therapy, people have problems that they want to change. So it's hard for me to see how this would not be relevant if a person needs to change, if they need to become less anxious, if they need to become more self-expressive. So it's not, I don't see this as, and this is the working through process. So I don't see this as being behavioral, solely behavioral. I think other orientations can nicely fit into that.
Great. Okay, so I have a couple of questions from Mary Coombs, and Mary, I'm going to open up your mic again so that you can ask them yourself. Go ahead. Your mic is now open.
Okay, thank you. Marv, I wonder, could you say something? I thought Paul Meehl was a really great example. And I believe that there was some personal, that he had very personal grounds for a very strong feeling, which had to do something about an illness that his mother had and a misdiagnosis. Do you remember any of that?
No, I don't.
Okay.
I never heard that.
Okay. And my second question is...
But an interesting thing about him that we can add is that he was very much influenced by Albert Ellis. And Albert Ellis was anything but research-based in talking about the importance of cognition. And what this illustrates to me is that the practicing clinician has what the philosophy of science has described as the context of discovery. The context of discovery is where you get your hypotheses from as to what's important. The context of confirmation is the research that confirms these hypotheses. So the clinical observation is the context of discovery, and the research is the context of verification. And that says something about a two-way bridge.
But thank you for adding that, because I think Paul Meehl, I think his mother, you know, it cost his mother's life, the fact that these two domains were so split off from each other.
Really? That's interesting. I hadn't heard that.
Yeah,
I'll have to go to Google.
Is, you know, you mentioned about the common, you know, the common shared ground. Is this Smith and Glass, you know, research that was done quite a long time ago? Is this still an important, I don't know, piece of information or research that, you know, could still potentially help pull together, you know, these domains that often just resist learning about one another?
Yes, there certainly is the resistance, and there are behavior therapists and CBT therapists that are very much against the contributions of Glass and Smith, and would say it's based on a meta-analysis, and the problems with the meta-analysis is it's garbage in, garbage out. It's only as good as the research. I think, though, what is happening is that there's an increasing number of studies that are showing no difference between certain CBT techniques and other orientations. And some of them happen to be my favorite CBT techniques, where it's like, it's very upsetting in one sense, but like the McCullough's treatment for chronic depression, while it showed great promise, did not fare any better than a more dynamically oriented approach. But the dynamically oriented approach and his approach probably had these same principles. And that, the same thing has happened with Marshall Linehan's DBT. And I'm certainly a major advocate of Linehan and what she's done. I think she's done brilliant work, and I'm not saying it simply because she was a student of mine, but because she has come up with great stuff. And one of her colleagues has demonstrated in a very well-controlled study that a more dynamically oriented approach to treating borderlines was just as good. So the question is, which of these principles? I think this is the way to go, to do research on this rather than the meta-analysis. How long it's going to take before some of my colleagues give up the notion that it's only CBT that is evidence remains to be seen.
So Marv, no more questions for now, and I'd suggest that you sort of blaze through, and then if we have time at the end, we'll take a few more questions.
Okay.
Sound good?
Basically what we did is we decided that we were going to create a two-way bridge. And we looked to see what was being done with research that came up with empirically supported treatments. And this was something that was done by the Clinical Psychology Division, Division 12, some years ago, headed by Diane Chambliss. And they came up with the FDA model. And this was the drug research model of clinical trials that the NIMH, National Institute of Mental Health, had fostered. That we're going to no longer treat problems in living, we're going to treat disorders. And we are going to use the clinical trial model so that if there are two or more clinical trials that show treatment A is better than treatment B or better than a good control group, we're going to put this on the list. It's like the Federal Drug Administration in the United States. If two or more trials show that a drug is useful and safe, then the pharmaceutical company can market it. But what the FDA does with drugs is that it provides a way in which the physician can report back any instances of problems in using the drug in clinical practice. So we decided we were going to do this. We were going to make our two-way bridge available so that the practicing therapist who is using an empirically supported treatment can say the problems that she or he has in clinical practice. And what we did is we developed surveys. And the surveys specifically focused on CBT because it's the CBT list of empirically supported treatments. And what we looked at is anxiety disorders. And we started with panic and social anxiety and general anxiety disorder. And we conducted web-based surveys, and perhaps some of you even participated in them. It was an international survey where we said we want to know about the variables that interfered with symptom reduction when you use CBT for treating social anxiety, for panic, and for GAD. Variables associated with the patient's symptoms, such as severity, chronicity, other patient problems, such as difficulty in functioning, patient expectations, recall common principle, beliefs about symptoms, patient's motivation, the social system, with a family, within a work situation, any limits with the intervention procedure, and any issues with the therapy relationships. So we conducted these surveys, and then subsequently, most recently, will be added to OCD and PTSD, and we're going to be doing stuff on depression as well. But the results of these first three are about to be published in a special issue of the journal Behavior Therapy, together with comments by therapy researchers, one of the therapy researchers being Diane Chambliss, who spearheaded the empirically supported treatment movement. And the comments are nice. I've read the draft of it. And the series will be out and posted on a website that I'm constructing after the first of the year. And if you're interested in the results of this, Sam, is there a way that I can get the email list of everyone and send out stuff at some point?
Yeah, I think we can do that. Maybe what we should do is we might want to just have people opt in. Why don't you let me and Kim think about a way we could
okay.
sort of get people to say, yes, please contact me with that information.
Right.
But yeah, we can do that.
Then I can send the link to the website. We will have the PDFs posted.
Okay.
So, I can't get into all of the results in the amount of time we have left, but let me just give you a couple of examples. And remember, these are CBT people that are saying, when I use this empirically supported treatment, I have problems under these conditions. So a large percentage of them for the first three disorders, panic, social anxiety, and general anxiety disorder, say that the chronicity of the problem creates difficulty in using the empirically supported treatment. They also say severity of the symptomatology creates a problem, but less so for panic. So 64% of the of the therapist treating social anxiety and 61% of the people treating GAD said that severity was a problem, but only a little over a third of the people treating panic. So severe panic disorder doesn't necessarily have a negative prognosis, not nearly as much as these two. And these two probably have an earlier onset, so that may certainly have something to do with it. Over 60% of the CBT therapists said poor motivation is a problem. A large percentage of them said one of the beliefs of their patients that created problems was the belief that they were going to do all the work, that the therapist would do the work, or that the medication would do the trick, or that they would be free of all anxiety. A smaller percentage, when it came to the therapy technique, said that the therapy relationship, said that that was a problem. There are still therapists out there that see the therapy alliance as the wheelbarrow and don't recognize that. Although a small percentage of them have acknowledged that the alliance probably wasn't strong enough to get the person to follow through on the therapy. So there is that as an issue. Another major issue that was reported was the patient's social system. And this is one of the limitations of individual therapy and individual CBT for these disorders, in that the clinical trials that have been used focus only on individual therapy, but a large percentage of the clinical problems that occur in using CBT in individual therapy occur because the social system is creating problems that are maybe diametrically opposed to what is going on in the therapy situation. Now, this initiative is part of what looks like maybe occurring as a more general movement in the field of psychotherapy. So it's not only the collaborative initiative of the two APA divisions, but also the work on practice research networks that Tom Borkovic started and that Louis Castonguay has been putting in a lot of effort to make happen, where therapists who are doing therapy are collaborating with researchers to find out about what variables, client variables, setting variables, treatment variables help the therapy or hinder the therapy. Louis and colleagues and students also published a chapter in the latest 6th edition of the classic Handbook of Psychotherapy and Behavior Change, the Bergen and Garfield one edited by Lambert. And they have a chapter that is dedicated to the collaboration between researchers and clinicians. Another thing, the Psychotherapy division of APA has a journal, Psychotherapy, and there was a special section that was published recently on possible ways to close the gap between research and practice. Conferences. The last SPR conference had as its theme, from psychotherapy research to practice and back. The Australian chapter of SPR, last conference, a dialogue between psychotherapy research and practice. How best can we learn from each other? And the recent CEPI conference in Barcelona, psychotherapy integration, researchers and clinicians working together. And finally, the Journal of Psychotherapy Integration, which goes to CEPI members, will begin a special series on practice-oriented evidence reviews. And Michael Constantino and I are co-editors of this special section. And what it does is it doesn't focus necessarily on empirically supported treatments based on clinical trials, but rather other basic research evidence that can help the clinician. So we have as our first review a review by Susan Anderson and colleague on person perception, namely how our prototypes, how our stereotypes, how our schemas of significant others formed early in life can distort our close relationships by causing us to misperceive others. And she does that in the context of transference, but it applies beyond psychodynamic therapy. A colleague of mine, Joanne Davila, has just finished a review on basic research on close relationships and how that can influence a couples therapy. So we see evidence as going beyond simply clinical trials, but all forms of evidence, evidence that deals with the process of change, evidence that deals with psychopathology, as well as evidence on clinical trials. The clinical trials tells us if therapy works. The process research tells us how therapy works. And the basic psychopathology tells us what needs to change in therapy. And all of this is a very important empirical backdrop for the practicing clinician. So the commercial, join SPR if you're a CEPI member, and join CEPI if you're an SPR member. We are trying to form closer collaborations between the two, and we're both pursuing the important theme of psychotherapy integration, specifically closing the gap between research and practice. And that's basically.
Thank you, Marv.
What I need to say.
So I think given the time, I think that we don't really have time for final questions. But I think that, you know, on behalf of the webinars committee, I want to thank you, Marv, for this excellent presentation, and I want to remind, because I'm getting a bunch of questions now about it, I want to remind our viewers that copies of this webinar will be available on SPR's website, so you can actually re-watch the entire webinar, review the slides, and if you missed anything, catch up on it. And we will post when that's available, and you can find it through SPR's website. We typically post every now and then on the SPR's Facebook page as well.
And the CEPI website as well, hopefully.
What's that? And
the CEPI website as well, hopefully.
Yes, we will post how to get on there from the CEPI website as well. And then I also want to remind all our viewers that the next webinar is on January 12th. January 13th, and that will be done by Larry Butler. So January 13th, the sign up for that will go out relatively soon, and thank you all for your participation. I know, Marv, that it's very weird not to be able to get a round of applause, but I hope that your ability to use imaginal experiencing can collect at least some of the accolades that we're getting sent to us via the questions. Lots of people saying thank you very much.
Thank you.